Hello, this is Dr. Corenman, and we're going to be discussing today interpreting lumbar spine X-ray images. When you have an X-ray, they're typically AP and lateral. They're typically also performed standing. It's helpful to know if they're standing or not. Sometimes there's a marker that's a level that'll tell you whether it is standing or not. But let's assume they're all standing. You have to have an algorithm to think about so that you can go through the X-ray in a standard fashion so you can identify normals and possibly abnormals. The first X-ray we'll start with is the AP. It's a very standard X-ray. You want to first look for scoliosis. The spine should be straight in the AP plane. You want to look for any angular collapses. The vertebra should be parallel to each other. You want to look for 5 lumbar vertebrae, L1, L2, L3, L4, L5, and then the sacrum. There's a slight lumbarization of S1 here. You want to look for pedicle shadows. So you want to look at these, what some people will call eyeballs, and you want to make sure these are intact. You want to look for rotation. Are the vertebrae normally aligned or are some rotated compared to others? We'll discuss how to do that in the later portion of this lecture. You want to look at the intercrestal line. Normally the intercrestal line goes through L4-5 and it gives you a landmark to understand if the pelvis has some abnormal findings. You want to look at the Sacro-Iliac joints. These are difficult joints to interpret, but we'll talk about the best ways to look at this. You want to look at hip integrity. Obviously, this X-ray has collimated out the hips, and X-ray techs will commonly do that. It's nice to have the hips, but if you're wondering if there's hip pathology, sometimes an AP pelvis is necessary. You want to look at facet contours. The facets lie directly over the pedicles, and you want to look to make sure they're not sclerotic, angulated, full of air. We'll talk about vacuum phenomenon. You want to look at pelvic alignment. Are the legs the same length, or is the pelvis sloped, causing a short leg? You want to look at the quality of the bone. This is normal, but if you look at X-rays enough, you'll get a feeling for osteoporosis, something called pencil-thin cortices. In adolescents, you'll see something called the Risser sign. Adolescents have open growth plates, and they end up ossifying the growth plate before it fuses. Now it fuses here in this apophysis, and if it's open, it means the patient is skeletally immature. And this apophysis has 4 areas, 1, 2, 3, 4. Once you get to 4, typically growth is over, and then 5 is when this growth plate fuses. This is another open growth plate just so you can get used to seeing what it looks like. The normal lateral X-ray is quite valuable. In fact, I call it the poor man's MRI because you can look at the lordosis, you can look at discal heights, you can look at alignment, whether the spine aligns nicely or whether there is a forward or aft alignment called a retrolesthesis or an anterolesthesis. You can look for pars integrity, you can look for the sacral angle, and you can look in the lower thoracic spine for Schurman's type changes, which we'll discuss later. The lordosis in the lumbar spine is generated by the trapezoidal shape of the discs. The vertebra, if you take the discs out and stack the vertebra one on top of another, you'll have a straight column. It is the trapezoidal angulation of the discs that cause the lordosis, and you can understand that if you have degenerative changes, you'll have some loss of lordosis. Flexion extension films are the most valuable series that you can get and even gain information that the MRI will not give you. These are the only stress and gravity imaging series that can indicate instability. And you want to compare and contrast flexion versus extension. Commonly, an X-ray tech will note flexion versus extension, but there are times when they won't, and you have to do this on your own. And a flexion extension film will reveal pars fractures, degenerative slips, discal incompetence, and retrolistheses, as well as, of course, spondylolistheses or anterolisthesis. The extension X-ray is the corollary of the flexion X-ray, and it's quite valuable to look for alignment. There are slips that you might see on flexion that reduce on extension, indicating some instability, versus a slip which does not correct on extension, indicating a more stable nature. The obliques are famous for the Scotty dog. And here you can see the Scotty dog where here's the eye, here's the ear, here's the nose, here's the front leg, and here's the back leg complex with the tail. What you're really looking at here is the transverse process, the pedicle, the superior facet, and the inferior facet. And the collar on the Scotty dog is famous for discussing if there is a pars fracture or an isthmic spondylolisthesis or listhesis. There is a view called the Ferguson View, which the X-ray tech will tilt the tube to make L5-S1 flat to the lumbar spine. So you could look at the pars here directly on, where you couldn't see that normally in a typical AP. There's a common problem called Bertolotti syndrome, or a transverse-alar articulation, where L5 has developed a large spinous and transverse process, and that articulates. So here, L1, again, this is a rib, so this is T12, L1, L2, L3, L4, and L5. And you'll notice there's a small transverse process here and a very large transverse process here with an articulation. That is a Bertolotti's syndrome. There are inlet-outlet views that you can look at the sacro-iliac joints in an easier fashion. This is showing you the inlet, and you can see the sacro-iliac joints here and here. Again, serpentiginous joints, very difficult to ascertain if there's arthritis, but you can look at the marginal corners to look for spur formation. AP again, great for hip joints. When you look at the hip, the acetabulum and the femoral head fit nicely together. It looks like it's floating in space, and the reason is there's articular cartilage which does not block the X-ray beam. So this is the articular cartilage space, and if it's uniform and there's no obvious spur formation or sclerosis of the sourcile, this is the sourcile here, then it's unlikely to have significant hip problems. Obviously won't show labral problems. There are lines called Mach lines which make false readings. So for example, here at C7, you can see the pedicle here, but you can't see the pedicle here. So you might say, oh my goodness, there's a missing pedicle, but it's not because of the volume of air in the trachea. It hides this, and that's a false finding. However, I want you to be aware if there is a missing pedicle, this one is intact, this one would be missing. There are tumors that can erode pedicles away. Sagittal disc heights on the lateral are very valuable because they can tell you the health and integrity of the disc. Typically, the disc becomes larger as you get down to L4-5 and then narrowed as you get to L5-S1. So for example, here, measuring in the center, 13 millimeter, 14.5, 14.6, 14.6, and 12.6. Commonly, this is 11 to 13 millimeters at L5-S1, and commonly somewhere around 14 at L4-5. Here's an obvious narrow disc. This is called isolated disc resorption, or IDR, at L5-S1, and you can see the increased bone deposition in the bony end plates of L5 and S1, and that's due to increased stress by something called Wolff's Law. Wolff's Law is bone that is under stress will lay down more bone. So this is an AP of a disc narrowing where you can see a little bit of an angular collapse at L4-5 and some disc narrowing at L5-S1. Obviously, on an AP, it's harder to determine disc narrowing than on a lateral. Here is mild disc narrowing. This is at L4-5, where you can see that L3-4 is a thicker disc than L4-5. So if you had an MRI, there'd be probably some degenerative change here at L4-5 and maybe even at L5-S1. There is more degenerative change here. The end plates are still intact. There's no sclerosis, but you can see the narrowing of the disc space. So an MRI would show a degenerative disc here at L5-S1. L4-5 here, in this case, L5-S1 is still thick at about 12 to 13 millimeters. L3-4 is about 14 millimeters, but L4-5 is probably about 3 to 4 millimeters with sclerosis of the end plate, and this would be IDR at L4-5. Here again, IDR with sclerosis at L5-S1. This disc has been under stress for a long time. The cushioning no longer works, which is why you see the increased whitening of the end plates. There is something called a vacuum phenomenon. If you look at the disc here at L5-S1, this is flexion, and here's extension, and you see now a black, thick line in the disc space. That's because there's nothing left of the disc. There's no fluid, and when you extend, you create a vacuum, and you draw in nitrogen and carbon dioxide gas, and you get this black line. That's an indication of a very degenerative disc. Rotation is noted if you want to compare the pedicle spacing to the spinous process, and you want to measure these two distances. And if you look carefully, this spinous process is closer to this side than to this, indicating rotation. You want to go down and check where the rotation starts, and you'll see that the same spacing is true here. It's shorter here than here. So if you keep going down, eventually you can find the source, unless, of course, the X-ray tech has the patient rotated, in which case you'll see rotation of all of the vertebra. Degenerative scoliosis typically occurs with rotation. Here at L5-S1, you can see the spacing between the spinous and the pedicle is about the same, but you get to L4-5, there's more rotation. In L3-4, there's almost no spacing here, where there's significant spacing here. You can measure the angulation by using something called the Cobb method. The Cobb method draws a line parallel to the vertebra and then a 90-degree angle subtended line, and then you measure the angulation. And that's how you measure through a Cobb vertebra. This is a typical degenerative scoliosis where you can see angular collapses, rotational changes, and this is a 32-degree scoliosis. You can use the Cobb angles in a complex scoliosis with a plumb line from C7 to determine if the spine is balanced. You'll see that the plumb line is within about 1 centimeter to 1.5 centimeters from midline. So this is a reasonably well-balanced curve. Short legs can also cause pelvic obliquity and scoliosis. If you look at the alignment here, this is a line parallel to the floor, which basically touches the femoral head on the right. On the left, the femoral head is substantially dropped, and this creates a pelvic tilt, and of course you'd probably see a scoliosis up above this level. So short legs can cause scoliosis. There are times when the scoliosis is uncompensated. So here's a patient with a massive scoliosis in the lumbar spine and not much in the thoracic spine. So the plumb line at C7 is about 15 to 17 centimeters off of midline. And obviously this patient would have to use a cane to walk because of the imbalance weighting the right side. You can have a scoliosis appearance from antalgia, which is not a true scoliosis, but it's a pain-induced angulation. For example, a large herniation right here will cause you to lean away so that the roots that are being impressed by this do not cause pain, and you'll see that there's no rotation in an antalgic scoliosis. You can measure the lordosis of the lumbar spine through the Cobb angle too. Again, L1 and the sacrum. Normal is 40 to 60 to 65 degrees. Here is 74, so a slight increased lordosis. If you have a flat back deformity from severe degenerative changes and erosion of the discs, you can see that the lumbar spine, for example, in this case, has a 20-degree curve where it should be between 40 to 65 degrees. The effect of a flat back syndrome is that you have to rotate your pelvis posteriorly, and some people with a flat back syndrome will have a bent knee gait and bent knee stance, so you can look for that. You can have a localized segmental kyphosis. If you'll notice, these discs are in lordosis and this disc is in kyphosis, and that's antalgic because there's a large herniation compressing the canal, and of course you need to flex forward to open the canal. So this is an antalgic kyphosis. You can have angular collapses of the vertebra. So you can see there's some asymmetric discal collapse here. So this is a significant angulation due to the fact that the disc is intact on the right and is not intact on the left. You can see that here with the sclerosis of the facet, and you see the hypertrophy of the facet. Facets that are sclerotic will also hypertrophy due to the increased stress. You can have a much greater angular collapse. If you notice, this is about a 26-degree angular collapse from 5, 4, 3, 2, 2, 3. So L2 is collapsed on L3, and you can imagine the nerve root that could get trapped in there. There are different kinds of spondylolistheses. The most typical ones are degenerative and isthmic, and we'll talk about those. This is a degenerative degenerative spondylolisthesis. You'll see the alignment here is relatively normal, and there's a slip from here to here, and that's because the facets have worn out here. That's a degenerative spondylolisthesis. Here's a case of isolated disc resorption at L5-S1 and a responding degenerative disc at L4-5 with a retrolisthesis, which is not uncommon. This is a rotary listhesis. If we look at L5-S1, it is collapsed on the right, but L4 has shifted to the right on L5 and is rotated. You can see that there's equal space between the pedicles and the spine is here, unequal space here. So we know the source of rotation is here, and that's because of a degenerative facet. There is evidence of rotation on a lateral. It's harder to see, but you'll remember that the vertebrae are more shaped like a heart than they are a square or a cube. And if you notice, these two line up here, and then here is the double density sign, because this vertebra is rotated forward or back on the back, and that'll show you the heart-shaped angulation of the vertebra. You can see that there is significant degenerative facet wear here at L4-5 above and over the pedicle, and there is an angulatory collapse as well as some rotation here. This is another degenerative spondylolisthesis. Again, L5 lines up nicely with a good disc height. There is no disc left at L4-5, and L4 is shifted forward on L5. There's no obvious pars fracture, so this is a degenerative spondylolisthesis. Now, degenerative spondylolistheses most commonly occur at L4-5, but I wanted to add one at L5-S1. The most common cause of slip at L5-S1 is an isthmic spondylolisthesis, but degeneratives also occur at L5-S1. Now, instability is measured through, as we talked about, flexion extension. Here, when the person bends backward on extension, there's a 4.5 millimeter slip, and when they bend forward on flexion, there's a 13.4 millimeter slip. Now, if you look carefully, you're going to see a pars defect. So this particular one is an unstable isthmic spondylolisthesis. I wanted to put this in. This is a myelogram of the canal, so you can see how the canal fills with flexion. And if you have problems with stenosis, the canal has what's called an apical type lesion in extension because the canal is cut off when you bend backward. This is why patients with stenosis will prefer to be forward flexed. Here is an isthmic spondylolisthesis. If you look carefully, you can see the break right here. You can see this is a grade 2. The vertebrae are scheduled 1 through 4, 25%, 50%, 75%, and 100%. This is between 30 to 40%, so this is a grade 2. You can have an undisplaced isthmic spondylolysis, but not listhesis or slip. Here, if you look carefully, you can see the fracture through the pars at L4. Sometimes you can't determine if there is a slip based upon an isthmic slip unless you flex. You'll see it's hard to determine if there is a fracture through the pars here, but when you flex forward, it becomes quite obvious. Ankylosing spondylitis, not very commonly seen, but this is what it looks like. It's called a bamboo spine, where you ossify the ligaments and create one solid piece of bone. Most commonly occurs starting in the sacro-iliac joints. We'll talk about that. Another sign is beginning of squaring of the vertebra. If you look at a normal vertebra, the vertebrae are concave in front. But if it starts to square, that's an earlier sign of ankylosing spondylitis. There are non-marginal syndesmophytes. Some people call these parrot beak spurs. And these are found on the spondyloarthropathies that are not ankylosing spondylitis, so psoriatic arthritis, enteric osteoarthropathies, and Reiter syndrome. If the sacro-iliac joints fuse, as you can see they're totally indistinct, you can't see any edges, that's going to be an ankylosing spondylitis. But if one side only is fused, it's going to be another spondyloarthropathy, as we talked about earlier. You can develop enthesopathy. So where ligaments insert into bone, once they start to tear off, you'll get bone growth at this area. That's called an enthesopathy. This is an Olympic gymnast who's unfortunately injured his back so many times he's developed stenosis at L1-2. There's a disease process called diffuse idiopathic skeletal hyperostosis, or DISH, and it's a flowing bone syndrome, commonly seen in diabetics, but you don't have to have diabetes to have this problem, but this makes the spine quite stiff. Typically, stiffness occurs even if the discs are not degenerative. Schurman's disorder is a disorder of soft end plates, so typically found in adolescents, where the end plates are softer than normal and they're typically athletic. They will develop end plate fractures and changes that are significant in the end plates, including Schmorl's nodes and irritability of the end plates. You can determine if somebody's had Schurman's in the past, as typically the vertebral bodies will become wider. As you remember, vertebra bodies typically will become wider as you go down, so the vertebra below should be wider than the vertebra above, but you'll notice L4 is about 45 millimeters. L3 is 54 millimeters, so that shouldn't occur, and this is because of Schurman's, where you can see the changes. Schurman's on an MRI shows you the end plate irregularities and destruction because of the soft bone. A limbus vertebra is very simply a disc herniation through the end plate. So if there are open end plates, you can have a disc herniation going through the end plate. And I was lucky enough to see a discogram where the discogram, the dye entered into the end plate. Here's the limbus vertebra. So you can understand the pathology of this. Compression fractures are typically found in patients with a trauma, although you can have old compression fractures also. The characteristic is that one edge will be flattened and narrowed in the front versus the back. So this is a fresh compression fracture. Burst fractures are different than compression fractures, as there's much more of the vertebral body that's involved. This is typically a 3-column injury, although occasionally it can be 2-column. One of the characteristics on an AP is widened pedicles. Now, just like the vertebral body should get thicker as you go down, the pedicle distance should get thicker or wider as you go down, and you'll see that this is wider than that, and that's because there's a burst fracture here. And the reason that we know it's a burst fracture is on the CT scan, you can see the significant damage of the vertebral body, allowing the 2 pedicles to become widened, and here's an injury to the facet joint. Endplate blurring is very difficult to see on some cases, but you have to be careful. If somebody comes into your office with back pain, maybe an ileus, and with spasms in the back, you have to be careful for osteomyelitis, because osteomyelitis can cause end plate destruction, which appears to be blurring. And so this is what an osteomyelitis looks like. It's gone through the end plate here and part of the end plate here, and that would blur down that. Here you can see an osteomyelitis at L3-4, and if you look carefully, you'll see erosions of the end plate. You'll see indistinct margins and some angular collapse. So this patient came into the office with an osteomyelitis of L3-4. The pelvis is important to look at for hips. Hips, as we talked about before, should be round, should be nicely marginated, and should look like they're floating in the acetabulum because of the intact cartilage. If you have collapse, you'll obviously see it. This is an avascular necrosis, and you can see that there's a little bit of narrowing of the margin here, indicating some probable arthritis, but here is collapse where the femoral head is no longer round but flattened. Here is a lateral view of the hip, and you can see instead of being round like the front of the hip, it's eroded and flattened, and this is avascular necrosis, but arthritis can look very similar to this. If you have a moth-eaten appearance of an area, you can be fooled because typical gas in the intestines will show up the same way, but you have to be a little suspicious sometimes. So this is a patient who had hip pain with some moth-eaten erosions, and if you look on the normal side, the hip is normally intact, and on the abnormal side, the hip acetabulum has been replaced by tumor. This is a sarcoma. The lateral is quite valuable to look for aortic aneurysms. Aneurysms will typically calcify, and so you can actually see the aneurysm and measure it. And this is important because obviously it's going to need a vascular consult. Charcot spines are spines that have been denervated, so typically paralytic patients. And what will happen is you'll get these bizarre erosions and this bizarre sclerosis. This is a typical Charcot spine in a patient who's had paraplegia for many years. Thank you for your attention. You're certainly welcome to visit my website, neckandback.com and studyspine.com for further information.